Sir, shall we start?
Starting.
Oh. Good morning, ladies and gentlemen. I hope all are at place and comfortable. So let's start today's program. National webinar on new treatment modalities in obstetrics and maternity nursing. Seminars are places where questions are explored, views are debated and analyzed, and participants are expected to contribute to the discussion with the resource person and each other. So we prepare to listen. Seminar is held for the exchange of useful information by members of a common business community. A webinar is an interactive seminar conducted via the World Wide Web. To start with, we shall welcome each and every member assembled here to the webinar, which is my primary responsibility. On behalf of all of us, I would like to welcome Dr. P.K. Padmakumar, Director and backbone of Center for Professional Advanced Studies. Welcome you, sir. Next, I would like to welcome Professor Abdul Salam N., Principal INE SME CPAS Pathanamthitta, who is delivering keynote address to this webinar. He is always with us, a driving force in organizing all such programs and other initiatives. Welcome, sir. I would like to welcome the resource person of the day, Daisy Varghese. Madam, she's a charge nurse in delivery suite in Latifa Women and Children Hospital, DHA, Dubai. In fact, we had several discussions with Madam regarding the programs. She had put earnest effort to bring this program a reality. Welcome, ma'am. Next, we would like to welcome the people of the BRAINIAC's convener, Jayachandran sir, Dr. Abdul Wahab sir, the coordinator of CPAS CTs, that is Dr. Sriraj KG sir, technical experts, Mr. Suresh Babu sir, Assistant Professor CT Paipad, and Suraj sir, Assistant Professor Stas Edapalli, for arranging this online platform, not only for this webinar alone, but for all sorts programs of CPAS. Welcome you, sir. Next, I would like to welcome all principals, vice principals, faculty from members from various reputed institutions, CPAS officials, students of various colleges, my fellow faculties, other teaching and non-teaching staff, and all other gathered here. Welcome all. Thank you. Next is a keynote address for which I request Professor Abdul Salam N., Principal INE SME CPAS Pathanamthitta. Please, sir. Sir, sound is not audible. Unmute.
Okay. Thank you.
Okay.
Very good morning to all of you. So our Joint Director SME, Jayendran sir, Abdul Wahab sir, resource person for today's seminar, Mrs. Daisy Varghese, teachers and MSc nursing students from various institutions. Good morning, all of you. It's extremely happy to note that Center for Professional and Advanced Studies, a society established under Ministry of Higher Education, Government of Kerala, is running almost 42 programs in the areas of medical and allied health sciences, engineering, applied sciences, journalism, library sciences, commerce, teacher education, and life sciences at both graduate and postgraduate levels. Nursing courses are in fact prestigious programs under CPAS, are presently catering to 6 centers. CPAS during the past few years are as part of quality assurance, is conducting a series of seminar and webinar sections, which present the academic institutions with the question of how educational department could offer a quality learning experiences to learners across the globe. It has provided a platform where we can have rapid interaction and almost instantaneous knowledge building and developing. I think this is the 9th section this year under CPAS, and second this academic year from Institute of Nursing Education, Chittipara, Pathanamthitta. CPAS strongly believe that this sort of sections is a main booster to ensure quality education in a rapidly changing world where education finds itself in the forefront of an instrument for social change. And we are lucky to have the service of Mrs. Daisy Varghese, an excellent speaker and an expert in maternity nursing, to be with us to discuss the matters concerning newer treatment modalities in obstetrical and maternity nursing. I'm happy to say that she's also my classmate at Government Nursing College, Thiruvananthapuram, during 1988-1992. Her experience and vast exposure in the field will be a real asset to all the participants. It's a high time that the maternity health personnel should have proper awareness in various treatment modalities that's happening elsewhere in the world. And we are awaiting a fruitful discussion, and I wish the section the very best. Thank you.
Thank you, sir, for your valuable keynote address. So we are not wasting our time. Next is our topic presentation. I request Madam Daisy Varghese, Charge Nurse in Delivery Suite in Latifa Women and Children Hospital, DHA, Dubai, to present the topic on new treatment modalities in obstetrics and maternity nursing. Please, ma'am.
Thank you so much. At the outset, I would like to thank Professor Abdul Salam, my classmate, as well as dear friend, for having extended me this opportunity to speak at the webinar. I'm very excited to be with you. Hope all of you had your cup of coffee and we are ready to start off. I would be giving you an overview on the new treatment modalities in obstetric and maternity nursing. So I will be basically talking on new trends, technology, and conclude with my references. Nursing and midwifery has seen a lot of changes over years. Each paradigm shift seems to bring a positive change in the healthcare system. Nurses and midwives over the years have improved in their professional and academic escapades. The healthcare system has seen the need to support nurses and midwives in order to achieve positive results. Healthcare worker safety is surely the priority for patient safety. When I did literature review, came across the pressure to transform healthcare has been building up for many years, and many frameworks have been proposed for this transformation. The triple aim concept of improving the healthcare population, health of the population, improving the experience of the patient, and controlling cost can be used as a guidepost for the adoption of the necessary changes to thrive in a new construct of women health care. Following these guiding principles should lead to improved clinical outcomes at affordable costs with high patient and provider satisfaction. The actual change will come in the form of various transformational forces. One of the driving forces will be the conversion of the current payment structure from a fee-for-service model to value-based payments. In addition, the method of care can be redesigned into a team-based approach in which providers and patients use best practice protocols that are individualized to specific patient needs. Redesign will continue to drive consolidation of providers into larger groups to cover the cost of needed infrastructure. External and internal pressures are causing rapid changes to the delivery of healthcare that markedly will influence the practice of obstetric and gynecology. These changes can be divided into three broad categories. One, burden of high cost on current healthcare care on society, the demographic changes in women that include aging, obesity, diversity, and chronic medical conditions. And thirdly, the workforce changes that include growing provider shortages, inexperience, and desire for improved lifestyles. The combination of these factors has brought healthcare into a strategic inflection point where current practice methods will lead to an inability to meet the demand for healthcare because of the increasing volume that's simultaneously controlling costs and improving quality. This necessitates providing women healthcare with a redesigned fashion with it to flourish in the new world of medicine. Revamping the delivery of women healthcare to meet the future demands will require a number of changes, and the reason for these changes suggested the use of triple aim concept, that is, improve the health of the population, enhance patient experience, and control costs that guideposts for changes and review in transformational forces of payment and care system reform. The valuable use of information technology and disruptive clinical technologies safeguards patient safety. The new healthcare system will require digital transformation so that there can be increased communication, availability of information, and ongoing assessment of clinical care. This will allow for more cost-effective individualized treatment as the data are securely shared between patients and providers. Scientific advances that radically change the clinical practice are coming at an accelerated pace as the underlying technologies of genetics, robotics, artificial intelligence, and molecular biology are translated into tools for diagnosis and treatment. Thriving in the new system not only will require time-honored traits such as leadership and compassion, but also will require the obstetrician and midwives to become comfortable with technology, care design, and quality improvement. So new trends in maternity and midwifery nursing is rapidly changing the world that required professionals to remain up to date in order to react to the new development as they occur. High quality care, evidence-based practice is the key strategy for improving maternal and newborn health, a critical component in the continuum of care. So when we talk of the trends in maternal and newborn health nursing, it came about because of the innovation, co-creation of evidence-based models in nursing practice, nursing research, and education. As we know, the goal for health for people 2020 is to reduce maternal mortality rate, reduce the rate of fetal and infant death, reduce preterm birth, and reduce cesarean birth among low birth women. We will speak one at a time. So to reduce the maternal mortality rate, what did we come up with? The WHO near-miss approach, maternal waiting homes, postpartum butterfly, transvaginal Bakri balloon replacement, the automated external defibrillator AED, and Lucas external cardiac compressor. So the near-miss approach, WHO in 2011 developed a standard approach for monitoring and implementing of critical interventions in maternal health care and proposes a systemic approach for assessing the quality of care. So who is responsible for the quality of maternal health care in the healthcare facility? Well, it's none other than the healthcare provider, the program manager, and the policy maker. So according to Pattinson, implementation of maternal near-miss approach in the healthcare services will serve what purpose? To determine the frequency of severe maternal complication, maternal near-miss cases, and maternal death, evaluate the healthcare facility or the healthcare system performance, determine the frequency of use of key interventions for prevention and management of severe complications related to pregnancy and childbirth, raise awareness regarding the quality of care issues, and foster changes towards improvement of maternal health. The purpose of near-miss approach to improve clinical practice, to reduce preventable morbidity and mortality using best evidence-based practices, used to monitoring and evaluating the quality of obstetric care, decrease maternal death, and improve maternal health. Now, maternal waiting homes are residential facilities located near the qualified medical facility where women defined as high risk can wait for their delivery and be transferred to nearby medical facility. Waiting homes have existed in Northern Europe, Canada, and United States. And this is to improve maternal health and neonatal health. They are also otherwise known as maternal shelters. Now, the issue for women reaching professional healthcare facilities, there were 3 delays. Delay in seeking appropriate medical help, delay in reaching appropriate facility, and delay in receiving adequate care. And that is why the concept of maternal waiting home came up with. So delay in approaching, the delay, what it led to. According to WHO, maternity waiting homes is an offer of a low-cost way to bring women closer to needed obstetric care, to reduce barriers of accessing birth facility, to go to hospital during labor, delivery, or in pregnancy if complications occur in appropriate time. So who are the people who are high risk? According to WHO, the women who could be admitted to maternal shelters are preemies or less than or para 5, then history where there is a history of perinatal death, history of operative or complicated delivery, a person who's of short stature, who's hypertensive, diabetic, has anemia, hydramnios, that is poly or anhydramnios or oligohydramnios, preeclamptic toxemias, then non-cephalic presentation and multiple pregnancies. So what are the services we get here? We get health services, basically, that is prenatal and postnatal care, physical examination, lab tests, 24-hour of nursing care, treatment of illness, and uncomplicated delivery of care. And educationally, what do they get? They get childbirth classes, that is preparation for the normal vaginal birth, then newborn care on breastfeeding, nutrition, family planning, and skill training. And the other services are, they get food, laundry services, recreational activities, childcare, ambulance services, and income generation. Now, if you see, there we have had there has been about each year about 50,000 women who lose their lives because of PPH. So thinking had been done on how to overcome the problem, and Liverpool Women's Hospital, after extensive consideration and consultation, came up with the postpartum hemorrhage butterfly. It is a novel device designed to treat PPH through uterine compression. It is less invasive, less tiring than traditional bimanual compression. So this is a plastic device which is inserted into the birth canal, which forms a platform against which the uterus can be compressed. The advantages: it is safe, cost-effective, need little training, effective intervention that can be used by midwives and could be of major advance in reducing maternal mortality from PPH, especially in rural resource settings where most deaths occur. Then came up the transvaginal Bakri balloon replacement. The Bakri balloon is a non-surgical option, an intrauterine device indicated to reduce or control PPH temporarily when conservative treatment is warranted. Then the cardiac pulmonary arrest, which is another common cause of losing mothers. So we came up with the automated external defibrillators, the AEDs, and the Lucas external cardiac compressors, which has been pretty helpful in saving mother's life. The next aspect we had to see was how to reduce the fetal and infant death. And this came through mobile or wireless continuous intermittent fetal monitoring, non-invasive prenatal testing, and vaginal seeding. The wireless fetal heart monitoring, or the Novi wireless PAC system, this is very much mother friendly because the women has the choice of moving about, and as well as the fetus is being monitored. So continuous monitoring is wearable device. This is a wearable device that provides continuous fetal monitoring, and intermittent monitoring by the no-wave wireless fetal heart also helps in monitoring the fetal heart. Now, the non-invasive prenatal testing is a genetic screening, which is a new genetic test that uses cell-free circulating fetal DNA in maternal serum to screen for most common aneuploidies such as trisomy 21, 18, and 13. Vaginal seeding, this is a procedure whereby vaginal fluid are applied to the newborn child delivered by cesarean section. The increased rate of because of the increased rate of cesarean delivery, the increase in frequency of atopic diseases and the risk for autoimmune disorders, eczema, asthma, rhinoconjunctivitis, obesity, diabetes has been taking a toll. So vaginal seeding has been helpful in this. Next was to reduce preterm birth. So what approach did we take? That was, research has confirmed that adding omega-3 in the diet of pregnant women has a positive effect on visual and cognitive development of the babies. And studies have also shown that higher consumption of omega-3 can reduce the risk of allergies in infants and also reduce preterm birth. So the main three categories of omega-3 fatty acid are ALA, EPA, and DHA. Now, the new approaches that were inducted to reduce the incidence of preterm birth, as we see, there are many causes for preterm birth, where one was maternal progesterone supplementation, putting of cervical cerclage, treatment of intrauterine infection to prevent exposure to smoking, then improvement in maternal nutrition and lifestyle modification to reduce maternal stress. With the increasing C-sections, reduction in this was also very important, especially in low-risk women. So WHO came up with the Robson classification. Now, if you see, this is a system or global standard for assessing, monitoring, and comparing C-section rates within healthcare facility over time and between facilities. So the classification, if you see, there are 10 classifications. That is nulliparous single women with less than 37 weeks of in spontaneous labor, then nulliparous single cephalic less than 37 weeks induced or CS before labor, multiparous excluding previous cesarean, single cephalic greater than 37 weeks in spontaneous labor, then multiparous single cephalic more than 37 weeks induced or CS before labor, previous CS with single cephalic more than 37 weeks, all nulliparous breaches, all multiparous breaches, all multiple pregnancies, all abnormal lies, and all single cephalic, less than 36 weeks. As we said, there was a triad, nursing education, new trends in nursing education of maternal and newborn health nursing includes tele nursing in maternity and mind map and concept map. Talking on tele nursing, nurses who deliver and manage and coordinate care and services using telecommunication technology are determined to provide tele nursing. Tele nursing may occur via interactive video discussions enabling visualization of the person to determine the appropriate care or education required. People receiving care can stay in their own homes, limiting the need for nurses to travel significant distances to see the client. Telecommunication for day-to-day during high pregnancy tests and steps includes electronic medical record, that is EMR, reviewing and making recommendations for care based on a patient's medical history and test results, all of which are detailed in the EMR. Genetic counseling, that is talking with patients about the risk factors or passing genetic conditions to their babies. Video conferencing, the doctor and patient can discuss the findings during ultrasound examination face-to-face over video. Virtual rounding, being an inpatient bedside across the state through mobile device technology. Mind mapping is nothing but a diagram used to visually organize information. A mind map is a hierarchical and shows relationship among pieces of whole. The mind map can also be drawn by hand, either by rough notes during the lecture, meeting, or planning sessions. Coming to the concept mapping, if you see, there are the physiological factors, all these factors can be taken into consideration, and a concept map can be drawn, which will help us in providing the best evidence-based care. Then the new technologies in maternity and newborn health nursing include robotic gynecological surgeries, the Vita heat during labor, virtual reality erase labor pains, massaging bras, clear tube digital pregnancy test, my peri-tense device, and the contraceptive computer chip. We will be talking on each of this. So robotic gynecological surgeries is a new field in surgery, especially in complex operations where movement is critical. It is capable of taking the patient's vitals, medical history, and updating of medical records. The robotic nurse plays an essential role in successful robotic surgery. As a part of the robotic surgical team, each one of the robotic nursing team, the nurse coordinator, the scrub nurse, the circulating nurse, has a certain job description to ensure maximum patient safety and robotic surgical efficiency. Well-structured training programs should be offered to the robotic nurse to be well-prepared, feel confident, and maintain high-quality care. And it is used for hysterectomy, tube ligations, removal of fibroid tumors and myomectomy, removal of ovarian cysts and tumors, infertility surgeries, endometriosis surgeries, and genetical prolapse surgeries. The Vita Heat is a portable system that moves with the woman throughout the entire labor and delivery process. The portable underbody system delivers warmth and helps to improve the woman's satisfaction and comfort, and also uses non-pharmacology pain relief. Virtual reality is one of the newest non-pharmacological labor pain management. This helps the patient to learn management skills during breathing exercise, meditation, visualization, using VR to distract from the pain is completely drug-free, and research has proven effectiveness of this during labor. A study has been done by Pravit to determine the effect of virtual reality using smartphone or pain reduction in primipara women during labor process, and they concluded that virtual reality is an effective complementary non-pharmacological method to reduce pain during labor. The massaging bras help to remove more milk into the breast pump. The milk is collected specially designed bag that fits inside the unit. It is used to stimulate milk glands that help to achieve the let down by using wireless rechargeable remote. The Lilu is a powered bra and has an inbuilt massager. It is used to prevent blocked milk ducts and is on the strategy of relieving breast engorgement. Next is the peri-tense device. This is a Kegel Exerciser, a muscle stimulator for women to strengthen the pelvic floor. It helps the woman with postpartum complications and incontinence. It is a stimulator technology and will do with pelvic exercises automatic. All we need to do is apply a lubricant on the stimulator and place the device comfortably inside the vagina with the silver parts facing the upper hips. Only 20 minutes a day can help a woman to get results effortlessly, and proven results are there. It helps for better bladder control, because after childbirth, women's pelvic floor muscles may have lost their tone and from atrophy or strain. It helps to regain and maintain bladder control. For women of all ages and sizes can avoid bladder leaks, urgency to urinate, urinary incontinence, and other pelvic floor issues. Now, the Clearview digital pregnancy test is a highly effective advanced digital pregnancy test. It is more than 99% accurate in detecting fertility. So it is basically a home ovulation test enabling women to measure their surge in luteinizing hormone to determine the most fertile days. Now, the contraceptual computer chip, that's a remote controlled device that can be that has been developed, and it is implanted under the woman's skin in releasing small dose of levonorgestrel daily, the safe, effective, long-term birth control. A small electric charge melts under the ultra-thin seal around the levonorgestrel, releasing about 30 microgram dose into the body for 16 years, and it can be turned on and off remotely when making family, and thus making family planning convenient. The device measures 20 millimeters into 20 millimeters into 7 millimeters and is available at competitive prices. Now, talking of trends in education, the new trend is Promise. This is a midwifery educational program to support the individual guidance of midwifery students towards proactive behavior in midwifery to cope with the numerous challenges in reproductive health care. Proactive behavior, an important coping mechanism for managing stress, gives higher job satisfaction, stronger commitment, and improved productivity in the team. To conclude, it is important for maternity nurses to recognize the new technology help to improve maternal and newborn health. Building skills, continuous training is very important to improve maternal health and improve the quality of care. And these are my references. Thank you so much for patient listening.
Thank you, madam. The section, I think it's finished fastly. Okay, madam. So really, ma'am, it was a wonderful sessions. Thank you very much for sharing your subject and practical knowledge, wisdom, and expertise. It's helped us improving our knowledge base and add on new inputs on the subject matter. Thank you, ma'am. Ma'am, so next is the interactive session. I request the participants to raise your queries, if any, and share your views and opinion. Those who are viewing this program through YouTube may express their queries through the chat box. Now the session is open for the discussions, open discussion.
Hello, this is Smita from AIMS Bhubaneswar, working as Associate Professor. It was a wonderful session, ma'am. We got to know quite a lot of things about recent advancement. Ma'am, I have a question for you. Ma'am, in your opinion, what is the application of artificial intelligence and machine learning in midwifery practice?
We are like in my situation, if I tell you, we are using the electronic medical record. So what happened, we have come up with a program wherein when a person comes to the healthcare facility, the history is documented, and this is across the whole country. Anywhere the client goes for any medical care to any practitioner, the record will give, once you put in the MRN, that is the medical record number of the client, you will get the history. So in case when you are taking history or when you're talking to the client, she has missed out on something, it will be there. The electronic record will give you a complete picture of the patient. So that enables you to provide holistic care. It's just an example. I think that answered your question.
I was just thinking like what else we could do par with the, in the medical, in the field of medical advancement where they are using artificial intelligence for diagnosis, prognosis, and also identification of issues of the patient. So similarly in midwifery, I was just thinking what else we could bring in for better patient care.
There are researches going on in UK, in Liverpool and all, which still nothing consolidate has come up so that I can give you a further input on that. It is in progress. They are trying to develop with technologies like certain implants which could help the women. It's still in progress. So I won't be able to answer you much on that at the present moment. Probably if you leave your email with me, I can get back to you.
Sure, ma'am, sure, ma'am. I'll drop it in the chat box.
Thank you so
Ma'am,
much.
yeah, this is regarding the applicability of these new technologies in Indian scenario. So let me just quote an example. One of my PG students, she is doing research on labor pain management using a virtual reality glass.
Yeah.
So the applicability part is very,
Yes.
very challenging when it comes to our situation, especially some of the challenges what she faced was the patient is pretty scared of the VR glass. Some of them even express that you make us wear this glass, you may swap our babies. Okay, so to put it theoretically, it's quite easy, but when we practically implement, especially in a low cost setting like ours, and we have a resource scarcity, the implementation of it has to be tailor made to our situation. And I guess we need to do quite a lot of research to put it into practice.
Can I add something there? I would
Yes,
like to
ma'am.
know, do you have antenatal classes for the women with whom you are doing this practice? Have
Uh,
you given them sessions on or video sessions where you can somebody can actually act it out and show what exactly happens? Like for example, in our situation, what we are doing is that I am one of the person who conduct childbirth classes. So in my childbirth class, I basically enact out, like for example, using of a birth ball. Many women are scared that in labor to use a birth ball, I might have a fall, it might harm my baby. So we literally enact out in pregnancy how it can be done and the benefits of it. So have you done something like that to cope up with your challenge that your student has faced?
she has done it, ma'am. Like you have a structured, antenatal clinic, but in our situation and in the state where we work, it is highly difficult to gather them even for minimum of 4 antenatal visits. Okay, so to motivate them to come to a clinic itself is a challenge. And the patients who come, they may be employed, they cannot even spend 15 to 20 minutes extra waiting time. So these are all the challenges we face. So even if we design something for the betterment of the patient cannot spare time. That is the issues what we have faced. And the education level is not to the mark that they are able to assimilate what we do, what we tell, or what we want to implement for our patients. But still, we are trying our maximum. There are people who would like to comply. The time is the biggest factor. The level of understanding is another factor. So, with all the constraints, we have been able to design something whereby we have done with cutting short the time. So, even though we know that the implementation would be better in a longer term, but still, with all this issues and hurdles, we have tailor made to fit into our situation. Let's see how it works out. Thank you, ma'am.
I highly appreciate the efforts that you have done, but I have a little suggestion from my practice because time is a factor. It is, and waiting time nobody likes. Everybody likes walk into the clinic, get your consultation done, and walk out. So in our practice, what we did was when we had initially we too had this hurdle of waiting time. So what we have tailored is that, what we have done is that during those periods, we put up videos in the language. Now here in this part of the world, if you see, Arabic is the language. So what we have done is that we have translated it into Arabic language. So with the general questions during our consultation, when patients come up with questions, the frequently asked questions, as well as how the practice, we continuously play the video while they wait in the clinic. So this is the time the patient can also prepare herself for the next. If she has some queries, if it is not if it is unanswered during her consultation with either with the midwife or with the obstetrician, she can clear herself. That's one thing we have done. Another thing is that what I understand, because I have not quite long not worked in India, so in my student period I have known that we have something called as the primary health care. Why don't you coordinate with the nurses or the ANMs in the primary health care facility? When you do home visits, show videos, because nowadays mobile is commonly available with everybody. Show them videos and prepare the women, so that when they come to the clinic, they have enough time to understand what their need is and how their needs will be catered to. It's just a suggestion.
Yeah, thank you so much, ma'am, for your suggestion. We will do that. And mostly, like AIMS is a government institution, and we are working with the Khorda PHCs and other PHCs. But our constraint is the resource. We have a lot of constraints on that, but still, with whatever is available, we are trying to overcome that, and we are trying to do the best for our patients. Thank you, ma'am. It was so good interacting with you. I'll drop in my email ID, and we could be in touch. Thank you so much.
Thank you so much. Appreciate.
Thank you so much, Nita ma'am, for queries. Through that, also we able to identify other aspects in the maternity nursing. Any other queries? Madam, can you explain to what extent regarding this new topic or new treatment modalities are being implemented in your hospital?
We have, as I told you, we have the electronic and medical records. Then we have something called as the maternity specialty clinics, because ours is a tertiary hospital. And to help women who are high risk, because in this part of the, not only in this part of the world, everywhere women like to be at home. And when care is at home, it is more comfortable, it is more relaxing. And we are a mother-friendly hospital. So mother-friendly means the mother should be at her utmost zone of comfort and have everything naturally. So even if she is high risk, instead of hospitalizing her and providing her the care, we have come up with the maternity specialty clinic, wherein we have early pregnancy assessment units, as well as feto-maternal medicine unit. So right from early pregnancy onwards, the women who need extra care pertaining to their history are cared to. They come to the clinic, they have regular visits, and they can be at home. And they can always get in touch with us anytime they have a need, and they are given with the necessary advice over the telephone, and they can come to the hospital. And if in case after consultation, telephonic consultation, there is a medication or anything that needs to be provided to them, we have the facility to provide that to their homes also. Coming to the maternity, when we speaking of pregnancy assessment unit, it is basically for women who are having PIH, or are diabetic, or have oligohydramnios or polyhydram. They are also very frequently monitored other than the routine antenatal checkups. So they can be at home, they come, they have their fetal check done, and according to the change in their condition, the needed advices are given to them, and they are catered so that they stay at home, and they only come to the hospital either when they are in labor, or if the time calls for them to be in the hospital, well, then they are hospitalized. So this helps us to be cost effective, and this helps us to reduce the patient stay in the hospital, help the mother to be more at home with her family, have the comfort of pregnancy going on and makes labor process eased.
There is a doubt in the chat box.
Sorry, yeah. Okay, I can see Preeti asking me, how can we prepare student nurses to get involved with the new modalities? Is that
Yes,
your
ma'am.
question, Preeti? Yes. So
Yes,
to
ma'am.
involve student nurses, if I understand correctly, I'm sorry, I'm not very familiar with the present education, the midwifery education system in India, because long time, as I told you, I'm out. I need to update myself on that. So what you could do is that right when they come in the fourth year, when they come into learning obstetric and midwifery, right from the start, in the class itself, teachers can prepare the student to look at various modalities in the particular situation, in the community where they are working, what is the need of the community in women healthcare, and where the students can contribute. They can prepare small talks, or they can prepare enacts where and how the new modalities are useful, explaining them the benefits, and then have sessions with the woman. It could be a casual talk, it could be a formal meeting, it could be a tele meeting, or what teleconferencing, whatever. To know first, you need to assess what are the need of the women in your community. Based on that, you have to brainstorm with your students how you can put the new modalities. So this empowers your student midwives or student nurses so that they can contribute to the effectively. So that will motivate their research mind, and also it will help them to look into the technologies that is available elsewhere in the world, the benefits that have been reaped out of the utilization of the technologies, and that will help them to adapt to the situation that the calls for them in their locality, with the help of your guidance as teachers. Did I answer your question, Preeti?
Yes, ma'am. Thank you.
Welcome. Yes.
One more point is there.
Yes, I did see
Yes.
that is Meenu asking me about epidural analgesia. Being a midwife means being with women. So if you are personally ask me, I'm not much in favor of epidural analgesia, but yes, if need be, the woman has every right to have painless labor. So here I said, being the midwifery skills come to play here. That is, especially through childbirth education and classes, women need to be prepared, because labor and delivery is a normal physiological process. It's not a disease, or it is not something to be scared of. And thank God, we all have been beautifully made by Lord so that we can go through the process. That is, we can withstand this stress both emotionally, mentally, physically, psychologically, in every way we are prepared. But because we are, everybody is skeptical about it, we need to prepare the woman. And believe me, and this is my experience, we all hear a lot of talk like, my experience is not your experience. So basically, you need the women to believe that it is she who is going to guide the healthcare professional to provide her the care she needs to make her labor and delivery a very happy one. So pain she is feeling. So if antenatally itself, we start preparing her on the various non-pharmacological measures, and to utilize them when she feels some mild cramps and pains, and to verbalize how effective she found it, this will help her or prepare her even before conception or in early pregnancy conception. When they plan itself, there are women who have dysmenorrhea, you can prepare them what are the various non-pharmacological measures they can utilize, and that basically is the exaggerated version of the dysmenorrhea, is what happens during labor pain. So she can prepare herself for it. That's one thing. Epidural analgesia is good, but you should always remember there are two sides of a coin, and there are its own I won't say defects, basically, complications. So that also you need to prepare the woman and leave it to the mother to make the choice, is what I would suggest from my practice. Was I
Thank you,
of
ma'am.
help to you, Minu?
Yes, ma'am. Thank you.
Welcome.
Thank you.
Any more queries, doubts?
Good morning, ma'am.
Good morning.
Nisha, ma'am. Actually, I am unable to join the initial stages of the classes, ma'am. So I am not able to know about the objectives of the classes. Actually, I'm having a doubt. Is the evidence clear that is it is necessary for the peritoneal preparation and enema before the stage of labor, ma'am?
Sorry, I didn't get you. Can you come again, please?
Yes, ma'am. Sure, ma'am. Is it necessary for the perineal shaving and the enema before the labor? Is it necessary or not?
It is not at all necessary,
Okay, ma'am.
because if you, it is against the initiative, that is the mother-friendly initiative. This is against it, and we don't favor it. And evidence don't show much that this helps in any way in improving the outcome of normal vaginal delivery.
Okay, ma'am. Ma'am, one more thing. During the antenatal period, our growth hormone is increased more than our during the stages of labor. Sorry, during the antenatal period. If it is necessary to take a thyroid tablet as a normal for this process.
Why do you need thyroxine? Why do you? Sorry, I didn't get you to. For what? Because the birth weight. The growth is rate is higher. What do you mean? What I couldn't get you because there's a disturbance in the net. Can you please rephrase it for me?
Yes, ma'am. Can you hear me now? Can you
Yes,
hear?
I can. Yeah. Yes.
The postnatal mothers, lot of the mothers are suffering from the thyroid problem, ma'am, hypothyroidism.
Mm-hmm.
Maybe it is a reason during the time of antenatal period if the mother is having this thyroid problem after the delivery, ma'am. Is there any evidence clear that it is related with antenatal period and hypothyroidism?
Well, in our practice, what we do is that her thyroid levels are monitored, and based on that, she continues with the taking of thyroxine, depending on her specific health condition. We don't stop them during pregnancy, and it is continued. And I haven't come across anything as such in my practice here.
Okay, ma'am. But I know a lot of mothers are suffering the problem. Myself also a victim for that. That's why I asked you, ma'am. Actually, I don't know. I don't have this thyroid problem earlier in my life. Actually, my second delivery, I got this thyroid problem, and my 2 to 3 colleagues also having the same problem. That's why I am asking to you, ma'am.
So I would like to know, did you do a screening for your thyroid pregnancy stage?
Yes, ma'am. Yes, ma'am. During the time of my pregnancy, it is normal only, ma'am.
And post, pre-pregnancy also you were normal?
Yes, ma'am. Normal only.
And during the pregnancy also you were normal?
Yes, ma'am. Normal only.
How often did you have your tests done? In the first trimester, second and third? All 3 trimesters, or just once?
Only once, ma'am. I think it's only once.
That was in your early pregnancy?
Yes, ma'am. I think it is 3 to 4 months, in between 3 to 4 months, ma'am.
Okay. So here, in our center, sometimes we do it in between to see, because maybe your lifestyle or your your stresses. I do not know what exactly. So we do a monitoring in case we find during our examination if some abnormality is there. We do a screening in between also. So then the necessary step could be taken.
Okay.
So just with one, so this you'll have to, you'll have to test it out and see what exactly is the reason for you having that problem.
Okay, ma'am. Actually, a lot of people are suffering this disease, hypothyroidism, after their delivery, ma'am. Because of the less monitoring may it happen.
It could be. Could be.
Okay, ma'am. Okay, ma'am. Thank you, ma'am. Thank you so much.
Welcome. You're welcome.
Okay, madam. Madam discussed so many non-pharmacological pain relief techniques during labor, like analgesics, anesthesia, like that. Is it any harm or problem with using birthing ball in the labor room during the second phase?
Well, there is nothing wrong. If you look into midwifery practices, we can use birth ball. It all depends on the comfort of the woman, how far she is prepared. We have in my setting, I have had women use birth ball up to she was 8 centimeters of dilatation. After that, I helped her onto the couch or the bed where she is to deliver, and then we also prepare women for taking various positions in birth. We normally don't go by the lithotomy position. She could adopt all fours. She could adopt left lateral position. It all depends on the woman. What is her preference? Even she can stand and deliver. She can kneel and deliver because gravity aids the process of normal delivery. So believing in that, we give our women the maximum opportunity to make the choice as to how they want to deliver. And it does help. Birth ball is wonderful. It helps to take off the pain women experience in the coccygeal region because of the position of the fetal head.
Thank you, ma'am.
Welcome.
Any more discussion? Any more interactions? Any more doubts? Okay. It was really a live interactive session. Lots of concerns and elements of topic was discussed for ensuring more clarity on it. Thank you everyone for your active participations. Special thanks to Daisy ma'am as well. I have a special
Yes.
I have a special announcement. The participants attended the webinar will be received a feedback form, which is intended to be reversed back duly filled. Those who submit the feedback form will be given a participation certificate of this webinar. I request all of you to do the same and get your certificate soon.
I would like to thank each and every one of you for your patient listening and the questions that you raised. I hope I was of help to you. And thank you so much once again, Abu and the team, for having given me this opportunity.
Anyway, it was a good session, ma'am. We know something, the topic related with this area, but madam add more area that comes under the novel technique like wireless fetal heart monitoring, genetic screening, vaginal seeding, then the treatment modalities comes under the preterm birth, etc. So it was really a wonderful session. So before winding up the program, I would like to request my colleague, Mrs. Amalayal, lecturer, INASME, CPAS Pathanamthitta, to deliver vote of thanks to all. Please, Amala.
Am I audible?
Yes, Amala, yes.
Good morning to all. It's a great honor and privilege to propose the vote of thanks on this occasion. Let me first of all start by giving glory to the Almighty God for making today's occasion a resounding success. First and foremost, I thank our director, Dr. P.K. Padmakumar, for his support and guidance for this program. Next, I thank Ms. Daisy Varghese, Charge Nurse, Delivery Institute in Latifa Hospital, Dubai, for giving a wonderful section on this. We have a little knowledge, but she has explored more. Thank you, ma'am, for joining for this program. We are grateful to our principal, Professor Abdul Salam sir, for his able guidance and encouragement for the success of this program. I also extend my gratitude to Vice Principal, Mrs. Emina Jose, for her guidance. We express our heartful thanks to BRAINIAC's coordinator, Dr. Sriraj KJ, and the technical expert, Suresh Babu sir, for the successful conduction of the program. We would like to express Our gratitude to all the estimated delegates for their presence and contribution to make this webinar a grand success. I express my heartfelt thanks to Mrs. Sienna ma'am for organizing this webinar. Last but not the least, I thank one and all who made this venture a grand success. Thank you all.
Thank you, Amila. So let's call it a day and hope to meet together in coming programs. Everyone stay safe and thank you. One and all, thank you. Thank you so much.